So, guys, well, we really need to talk about Clozaril patients. So let's talk about. Screwing it up already. Let's talk about Clozaril patients. Clozaril. It also clozapine. I don't want anybody to, be left out because it's confusing. It shouldn't be. Clozapine used to have a REMS program, and I kind of liked it. It was training wheels. REMS programs are things where the government comes in. I forget what REMS actually stands for, but the government comes in and makes everybody involved in the prescription and distribution of a medication. Uh, Basically, submit a bunch of stuff to a government website before it can happen. So, what used to happen with the Clozaril REMS was, it was very regimented. How all the labs would work. Because it used to be that you had to do it weekly for a certain amount of time, and then you'd go to monthly for in perpetuity, and that those numbers actually had to be in, otherwise the pharmacy wouldn't be allowed to fill the medication. They got rid of that, and now we're without our training wheels. We are cast away. But really, I mean, we just need to be careful with these patients, and that's why I'm making this video. I really want you guys to know a little bit about clozapine, have a healthy respect for clozapine, and to be talking to attendings about clozapine. Especially when there's anything even slightly a tiny bit out of the ordinary with these patients. So, clozapine, everybody is worried about the ANC, the neutrophil count. However it's displayed, we want it to be bigger than 1.5. So if you do a CBC with diff and you're looking at the neutrophils and you see like a number with like a number, decimal, and a number, then we want it above 1.5. If you see like four numbers in a row, then we want it above 1500. Sometimes it is, depending on the lab, you can have labs that, the units change. So don't let that throw you. But 1.5 or 1500 is the important thing to know. So some patients that are between 1 and 1.5 have this thing called BEN, which is like a benign ethnic neutropenia. And I feel like that is a complicating factor that makes everybody think that figuring out if the labs are good is complicated. But technically, there are some ethnicities where, for some reason, on average, people can have a lower ANC count and still have perfectly fine immune systems. So, you can look this up if you want to. But basically, I mean, as long as we're above the 1.5 here, that's what's important. So when we're starting people off, we get starting, you get weekly labs. I think it's after a certain amount of months, but let's say greater than 6 months, you go to monthly labs. And the ANC isn't the only thing we look at. We look at the ANC. We look at, let's see, what else do we look at? We look at the Clozaril level. And we look at the norclozaril level. And you can use the reference ranges from whatever lab. The exact numbers aren't important, but it's good to be able to see some data with regards to especially the ratio of the Clozaril to Clozaril um, levels, because that can actually tell you something about the side effects. So, um, and you can actually in the patient manipulate the ratio a bit by changing other medications. Luvox actually gets used for this purpose. So for anybody who really wants to dive in to some advanced stuff with clozapine, you can learn about how Luvox is used to manipulate the ratio of Clozaril to Norclozaril metabolites. But anyways, so we just want to make sure that the Clozaril level is adequate and not in a dangerously high place, and that the ANC is fine. And then we want to make sure, and this is not a lab, but we need to make sure that they are pooping. They need to be pooping. You got to make sure that your patients are pooping. And this might be something you don't talk about with all your patients, and that's fine. But with every single Clozaril patient, by God, I want you asking them about their poop. You have to ask them about their poop. I can't emphasize this enough. Your patients need to be pooping. So the problem is that people die. There. Does that scare you? It should scare you. Yes. People stop pooping to the point that they die on Clozaril. It happens. So let's not have it happen here. Okay? We really need you to be making sure that your patients are pooping. And you can talk to them about, like, are you straining? Is it like, are you going once a day? Are you going like once a week or something? Because really, by so day 5, well, this is what I tell people: an outpatient, I say go to urgent care and get an enema. Go to urgent care and don't leave until they force you to poop. Never allow it to get past day 5. So in the hospital, I don't know if they'll actually do an enema on our wards, probably not, but we have so first line of defense here. Okay, well, so before I get totally lost in the GI stuff, so I mean, all antipsychotics can cause constipation, but Clozaril is the king of constipation. Clozaril is the king of constipation. It literally can kill you from constipation. All right, and what happens is, like, it basically becomes such a brick that it rips the intestine open, and then, the bad news bears. So we really need you to make sure that everybody's pooping. And so what do we got at our disposal? We got Docusate. That is the most mellow. If Docusate works, I love it. I think 100 BID, something like that. You guys can check me on that. And then the next step would be mag citrate. I usually skip that and kind of just go to polyethylene glycol. And this gets a bad rep because that's what's in the prep for colonoscopies, and so you think like, well, geez, we're not trying to make the guy like poop so much that he's pooping clear water, and I agree. But when they do the prep for colonoscopy, it's a huge amount. It's like hundreds of grams, and here we use like 17 or 34 grams. I think grams. And it's a powder. It dissolves easily in water. You just kind of pour it in whatever amount of water you want, and it dissolves pretty readily. And then you drink the water, and then there you go. And then you're pooping. So I do favor osmotics over spasmodics. So let's get this straight. Do not use Senna. Do not use it. Not with Clozaril patients, because what Senna does is it makes the peristalsis, the contraction of the muscle fibers. It makes that a lot stronger. That's how Senna works, and if you're doing that onto a brick, it creates the threat of a bowel rupture. So just don't use Senna. We want to make the poop soft. We don't want to exert a lot of muscular force. Um, okay. And when we're talking about dosing, so if people come in on a Clozaril dose that's like any number other than zero, really, like let's say 200 or 400 or 800, and that could be split up like 200 BID, 100 BID, 300 BID, 100 AM, 300 PM. Like there's Clozaril clinics that really I try and optimize people. So any dose like that, if they come in, what do we do? We keep their dose, and we do that right away because if there's greater than 3 days off the med, bad news bear situation, you got to restart titration. And that's where that's where it's all of a sudden we're going to have the patient with us for 2 weeks or more. It's a big hassle. So we really want to try and avoid that. But if we are in that place, we need to know what to do. So what do you do when you're restarting a Clozaril titration? Well, 25 milligrams, day one. And then you go 25 BID, and then 25 AM, 50 HS, and then 50 BID, and then 50 AM and 75 HS. So you see what's happening is we're adding, so this would be day 2, day 3, day 4, and day 5. So basically, we add 25 milligrams a day, and we create split dosing, morning and night. And if one of the numbers has to be bigger, it just makes sense to put the bigger one on the night. I mean, that's just common form. But basically, you climb all the way to 200, going at 25 milligrams a day. And of course, you would stop this titration if there were a problem, if the patient wasn't tolerating it, if they stopped pooping, or also if they had a fever of unknown origin, or let's see what else can go wrong. Chest pains. Like we want to make sure that when we're titrating, that we're not causing myocarditis. It is a rare side effect that you can cause myocarditis. So just be aware. There's like a million ways that this medication is going to kill your patients. So please be careful with them. Myocarditis, we don't want it. So if they get random, well, first off, we have to be checking for it, right? So we have to be asking the nurses, please check temperature at least, once or twice a day. I'm just kidding. I don't think we actually have to ask them. I mean, I hope that this is something that is happening often, but just make sure you're checking the vitals, and if something's out of range, pay attention to it. And if they start saying that they have a tummy ache, you know, might be a bowel obstruction. So you just want to be really careful with them. And yeah, so you do this increasing by 25 milligrams all the way up to 200, and then you can be a little more liberal, and you can kind of just like start jumping by 50 or and even 100 after that. But the real walk is to get to 200. And then a lot of people who have already been on Clozaril, like you will know by a certain point, like, you know, from reading records or talking to their family or something, that, oh, the dose that works for them is 200 in the morning, 400 in the evening. And so once you get to 200, then, you know, you can be a bit of a cowboy. Then it's like, you know, only like 3 days more needed. You have the one day at 200, and then you might do, like, if you're trying to get somebody onto, you know, let's say 200 BID, then the next day you might just do 100, 200, and the next day 200, 200. As long as they're doing well at that and everything seems to be pointing north, then you discharge them with good outpatient follow-up, and everybody's happy. But you know, so we're not just worried about the ANC. So things to worry about. We have ANC, right? So like worry, yay! Let's worry about things. So ANC, yeah, you do worry about it because this neutropenia thing can happen. It's not actually the most common thing. It's just for some reason the thing that everybody was afraid was going to be a litigious target, and so it just became everybody's obsession. But yeah, so ANC, we worry about it, and then we also worry about pooping, and you don't want to stop worrying about the pooping. You got to keep worrying about it because I want you to make sure that our patients are pooping. And, you know, then also chest pain, like heart related, you know, we don't want their hearts to stop beating and stuff. So, yeah. So worry about those things and talk to attendings and be careful with Clozaril patients. They can seem like some of the most simple patients because the medication works so well, which is why we put up with all this complicated BS. It works amazing. But there is a lot of complicated BS around it. So, you know, talk to your attendings about it. And if you see any disruption in any disruption, like either lab or otherwise, um, with these people, make it known. Don't be quiet. So be a loud person. And other than that, you know, I love you guys. You guys make the hospital work. You know, we're an amazing team. And I hope that this message has found you on a beautiful day. And go team.